Dr. Erica Mallory Blythe is a UK-trained medical doctor with a background in trauma and emergency medicine. She's founder and director of FIRE, the Physicians' Health Initiative for Radiation and Environment.
Good evening, I'm Erica Mallory Blythe, and I want to say a massive thank you to the EMF Medical Conference 2021 for asking me to lecture this evening about prevention, diagnosis and management of electromagnetic hypersensitivity, or EHS. My background is emergency trauma medicine, and I worked within the UK national medical system for about 10 years in various disciplines related to that. And then about 10 years ago, I got into electromagnetic health research. And in the course of this, I noticed a couple of things. Firstly, that this is a rapidly evolving new area of important medicine. And secondly, that current levels of awareness and education were really poor. And so I put together a group called Physicians' Health Initiative for Radiation and Environment. That's FIRE. And you'll see that from my declarations here, I sit on a number of other international advisory groups. So in an hour, I'm going to very briefly introduce some important fast facts about non-ionising radiation and then get straight into diagnostic tools, management techniques and targets, and moving forward in mitigation. So some fast facts about radio frequency. It can damage biology at very low intensity, so-called non-thermal exposures. And there are no current safety limits either here in the UK or in the US to prevent against that kind of damage. What we have is the ICNIRP limits, which protect only against acute thermal damages. So a bit like heating cells in a microwave, these thermally induced measurable changes in temperature. And to confuse things a little more, the biological disruption is not linearly proportional to either the intensity or frequency of radiation. There are windows where lower frequencies and lower intensities can potentially show actually a high level of biological interaction or damage. So getting now straight into electromagnetic hypersensitivity, I defined this some years ago as a multi-systemic condition characterised by increased sensitivity to electromagnetic fields of increasingly broader frequency ranges at lower and lower intensities. And in practical terms, what I mean by this is you might have a patient report that they have some warmth or discomfort around their ear when they use a cell phone, a very common early stage of EHS. That can progress into headaches. And instinctively that person will move the phone further away, but they may find the headaches still occur, and it can even start occurring when somebody else uses a cell phone a very substantial distance away. Left unmanaged, that can then progress so that they develop a whole set of different symptoms to a broader range of frequencies. So for example, Wi-Fi type radiation, and even low frequency fields from things like household wiring or overhead power lines. The symptoms are very broad ranging. They're not non-specific. I don't really like that term because specifically they're induced by electromagnetic field exposures. That's one of the things that's specific about them. Additionally, there are specific constellations of very common symptoms, and this is classically headaches, insomnia, tinnitus, cardiac palpitations, dizziness. Those are some of the core symptoms that are actually very reproducible in the literature. And here's a few publications that report those symptoms, and there are many, many more now showing this quite predictable constellation. There are 3 phases to development of this, and we don't have time to go into detail, but there is likely to be some elements of predisposition, and dosages can depend on the size of the organism, which is also linked to gender, for example. Toxicity, especially with things like heavy metals, may also increase risk. But there needs to be a triggering event, and what's really interesting is although this trigger is normally electromagnetic, it actually doesn't have to be. It could be, for example, a heavy chemical toxic exposure. It can be a variety of things which increase the body's requirement for defence. But for maintenance, in order for us to call this electromagnetic hypersensitivity, the trigger of the symptoms through time must be electromagnetic field mediated. Otherwise, we're looking at a different diagnosis, for example, if it's chemicals, multiple chemical sensitivity. And in reality, we often see these environmental sensitivities go side by side in the same patient group. Straight into diagnosis now. This is currently a clinical diagnosis, so it's based on history and examination. And I mentioned that the symptoms are broad ranging, they involve every system, but here I've put asterisks next to some of the more unusual symptoms that might give you a clue in the history, because you won't have necessarily heard of these before. They're not common. This is electric shocks, a vibration sense, often inside the body. We've talked about increased chemical sensitivity, but they can have upregulation of all senses. They can find their hearing is very sensitive, and there can be changes in their vision that are very similar to scotopic syndrome, for example. And symptoms are collected if the phenomenon is left unmanaged, and they will relinquish those symptoms very often in the reverse order that they were collected. And there's some sense in that when we look at neural pathways. Circadian rhythm reversal, very common as in the later stages of EHS in those who've had insomnia. Now, if it's a history-based diagnosis, we need to take a very in-depth history. And I'm aiming this talk at physicians who aren't necessarily environmental specialists. So you can download a pro forma from the Europa EM International EMF Guideline 2016, and that gives a detailed environmental history so that you can fill that out at the beginning. But then I think it's very useful to ask some direct questions that are relevant to EHS. And I've put together this for research purposes, but it's very useful diagnostically as well. I call this a device or location chart. And what I mean by this is patients will often explain to you they have a certain set of symptoms that are unique to a certain type of exposure, and they may have identified it in response to a phone or in response to a computer, and they might be slightly different responses. And they may not know what the emission is, in which case they might say, this is what I get at the shopping centre. So this is why they might tell you the device, or they may tell you a location. But this allows you to group certain symptoms that they've identified as being caused by certain locations or exposures. As part of that chart, I have an area to record the onset and offset of their reaction. So when they're near that emission, how fast do they respond and have symptoms, and how fast do those symptoms disappear, and how close does that emission need to be? These, when you record those, give you an idea of the intensity and the frequency of radiation that's triggering them. And if you keep that record over time, you can see if your management plan has been successful. Now, they may not give you the diagnosis on a plate. They may just have classical symptoms and you're suspicious as a physician who is now aware of this condition. And something to ask about is, are they sensitive to weather changes? We have many decades of literature about spherics reactions. We know that there are very substantial changes in voltage that take place leading up to a thunderstorm, and many people get migrainous type headaches in response to this, and though that is EHS, that's exactly what that is. Now, obviously, for this to be EHS, then the symptoms that are caused by that must resolve when the EMF trigger is taken away. And that sounds very simple. In practice, it can be a little bit more challenging to do that because they might have multiple environmental sensitivities. But I'll talk through that more in a moment. Body heart spots are quite unique to EHS, I think, but areas of high intensity exposure. So this might be the temple on their dominant hand side from a phone, or it might be a mouse, their hand from a mouse, or it might be a foot even for an accelerator pedal in a car, which can have quite a high EMF. These are examples. That area can become hypersensitive over time, a bit like sunburned skin, where even a small exposure from a different type of EMF source can hurt in that area when it's been overexposed. And we sometimes see an interesting set of relieving factors, and this might be bathing or moving or shielding, for example. Bathing is probably dissipation of static charge. I mentioned that some of these patients have a huge number of electric shocks, more than average, and they may be holding a lot of static charge, and grounding them in this way might help. moving is because this is not a time-locked phenomenon. It's not like a light switch where it turns on and there's a reaction that is a very reproducible time period afterwards. It's not like that, it's variable. And so the individual might be able to outrun their symptoms if they move through different types of EMF quickly enough. And so they sometimes report relief by walking quickly or being in a car, as long as they're not reacting to the EMFs in the car. Shielding is an obvious one, and we'll say more about that momentarily. And here are some pitfalls, because even for diagnosticians that are aware of this diagnosis, if they're not really familiar with the condition, they may be confused by some of these reports in the history. So very weak field triggers in more severe patients can cause symptoms, and this might be just batteries in a remote control, or it might be an airplane which is a long way away from the radar. These are measurable fields, so it's not really a surprise. We know that the body has an incredible capacity to amplify tiny amounts, for example, of allergen in terms of a life-threatening response, and we can see something similar happening here with even tiny exposure doses. White noise obfuscation is a term that I put together some years ago based on anecdotal evidence where some individuals have made their home, for example, low EMF, and if one person comes in with a cell phone, they can get a very severe response to that, and they know they have a very clear reaction to it. And then they can be confused, as well as you as a diagnostician, by the fact that they might say, but then I go into town or a cafe and there are phones and computers everywhere, and actually I don't get that very severe reaction. Left in that environment, they will usually globally become quite unwell over time, but they don't have such an acute severe response. So that, I think, is because of layers and layers of complex EMFs causing a white noise type background picture, which the body cannot recognize and mount a response to as clearly. And this is not something published at this point. This is just an observation of my own. Now, the other side of that coin is actually very useful diagnostically. It's what we call unmasking in low toxicity environments. So conversely, if you take somebody, for example, who's been living in a block of flats and has loads of exposures and has a lot of the symptoms of EHS, but they're not sure that's what it is, and neither are you. If you can get them to a very pure, low EMF, low chemical environment, and then introduce EMF sources clearly one by one, you can then see, you can unmask their condition and see far more clearly what exactly is causing the triggers. And you can do the same thing with chemicals. Now, emotional exacerbation is quite common, and this is not because the underlying condition is a psychological one. It's similar to, let's say, a patient with a pheochromocytoma who's got headaches related to high blood pressure. They might say, and if I have an argument or get distressed, it gets much worse because it's pushing their fight and flight nervous system. There's a lot of common sense here. The psychiatry overlap here is quite complex and deserves a lecture entirely in its own right, but I'm just going to mention that I've been asked to intervene over the last decade a number of times with psychiatric units for two primary reasons. One, either the person has reported EMF to a doctor who knows nothing about EHS as being their cause for symptoms, and therefore been labelled as a psychiatric patient as delusional because they think that these fields could be affecting their health, but they've actually got no mental illness whatsoever. That has been quite common, and some of that group even managed to get sectioned under the Mental Health Act. But once some peer-reviewed literature is shared with the psychiatric group and there's been a good discussion, if there are no other signs of mental illness, normally that is no problem. The patients move into a different management pathway, thankfully. The other group are far more complex, and this is people who genuinely do have psychiatric issues, and these may be primary or secondary in EHS. But what's really essential, the message I want to get across here, is that we need to have areas in all different specialties within hospital medicine now that have low EMF, low chemical environments in which we can properly manage these patients. And that is absolutely important in psychiatric units, where if they've got complex illness, that the EHS element, if they have that, can certainly be exacerbated. I put together a staging criteria quite a few years ago now for research purposes, but it's very useful in diagnosing. And I've put a circle here around stage 1 because that is where I want these patients to be picked up. My work is very focused on trying to get primary care physicians and non-specialist, non-environmental specialist doctors recognising this at the earliest stage, because this is where patients are reversible, potentially. Once they get to stage 2 and 3, we can push them into remission, but full reversibility I have not seen. And this stage 1, which is characterised by very mild symptoms, and often the person themselves has no idea what's causing those, can be omitted entirely if there's been an acute, very high intensity exposure. Classic example of this is the mobile phone base station worker who thinks the mast is switched off, and unfortunately by accident it's been on. They've had a very high intensity exposure. They can jump straight to stage 2 or even stage 3. And those kind of case reports have been written up and published in the literature, so you'll see those. Stage 2 is classically some moderate symptoms, sometimes some severe, and they've usually recognised the cause of these symptoms now because their onset reactions are more rapid. And in this group, they may have started to implement some changes in lifestyle to mitigate that. Stage 3 must include severe symptoms, and this group sometimes have very extreme forced lifestyle changes. Stage 4 is when we've implemented our management protocol and hopefully they're in full or at least partial remission. I'll speak more about that when we talk about prognosis. And in that stage, you may find that cumulative or delayed symptoms are more noticeable because of the absence of these acute symptoms. Examination, I would say, is primarily normal in this group, but more work needs to be done here for sure. We need more publications looking at larger groups and using staging. But my suspicion would be that in stage 3, any of these kind of stigmata of disease may be apparent. And we have seen some of this in this group. We would hope, though, that those would disappear in stage 4 in remission. I want to bring all this together now in a structure. So we've talked through history and exam, and this is the point at which I hope we could consider making a diagnosis. And if you're diagnosing EHS based on your findings, then you might want to consider some adjunctive testing in the form of blood tests that we'll talk about in a moment, and possibly even some types of scanning. And that's based on some publications which I'll point out. You absolutely must think at this stage about surveillance. You can't avoid something that you can't see. So this group need to be using meters, whether they're purchased themselves or hired, or they have an expert company come in and survey their environment, because that is the way that they can implement the management plan. And I've got a structure that I advocate here called the A2H's approach that I'll move on to discuss. Looking on the right side of this flowchart, if you haven't diagnosed EHS, you're obviously looking for other sources of pathology to explain their symptoms. And of course, we're doing this all the while, even if we have diagnosed EHS. It's good practice in all areas of medicine. And at this point, I want to point out a common conundrum, which is that some of the headaches seen in EHS can be red flag type headaches. They can be severe, they can be sharp, they can wake people up in the middle of the night. And that will rightly lead to some concern and suspicion that maybe they need imaging techniques to rule out something like a space-occupying lesion. This can be tricky because the individual might feel understandably concerned about undergoing a radiological investigation, which will subject them to EMF. One of the things that I would suggest in this scenario is to discuss this with the radiology department and reinforce the principle that they should already have, that the lowest possible dose of radiation must be that's used for investigation. And other forms of scan are being advocated for research purposes in EHS. So some work's been done on looking at functional MRI in this group. I would just say, please be careful, be very clear with the people involved that if it's not going to alter their management, if you're not using that to look for pathology, it's just for interest and research, it could exacerbate symptoms, and they need to be aware of that to give informed consent. This brings me on to provocation testing, and I just want to say a few words about that, because that again is an EMF exposure that won't necessarily alter management. So what I mean by provocation studies is introducing in a double-blind scenario an electromagnetic field. And in some aspects, this has been going on for many years, ever since mankind started playing with electromagnetic fields. And some of the early ways in which this was being done was, for example, the electric kiss, which was where a lady would be charged up with a static charge and discharge that through a very exciting kiss. And even back in these early stages of messing around, we started to see documentation of EHS in letters, in texts, in doctors' reports, in books. And it's interesting looking back at that, because again, we see these constellations that are reproducible. But these, us as medical professionals noting a response to an exposure began to become more and more scientific. And here's some of the first studies of this type were done by William Ray that showed that people could demonstrate under double-blind conditions a somatic response to EMF. This is another study published in the International Journal of Neuroscience in 2011. And I'll just read the last line of the conclusion here. EMF hypersensitivity can occur as a bona fide environmentally induced neurological syndrome. Why do I point this out? Well, it's the kind of gold standard of proving what is causing this condition. And the reason that we need to discuss this is because at the moment, people with EHS, when they present to their medical doctors, are too often told, don't worry, your cell phone isn't causing your headache, it's the nocebo response, which is symptoms induced by fear or concern of adverse health effects. Now, this is the obvious way in which to disprove that reaction. But once you've done that once, and actually this has been done more than once, then you can say this can happen. It is a real phenomenon. You can't subject people repeatedly to this kind of test. It's not ethical. It's a bit like somebody coming in saying they get migraines caused by coffee, and you say, well, I don't believe you. Drink a cup of coffee and let's see if you get a headache. That's not an appropriate way for us to manage this patient group. But the reason I brought this up is because despite the fact this has been shown under those conditions, the majority of studies done of this type have failed to show that relationship. And the reason that they have failed, in my opinion, is methodological flaws. You have to be really experienced with EHS and have heard a lot of EHS histories in order to understand the nuances. For example, the fact that this is not a linear reaction, the fact that it's not time locked, the fact that we can have these extremely weak field triggers, the fact that there can be cumulative or delayed symptoms. All of these things make this kind of test extremely complex, and it is that complexity that has led to many of these studies not showing that relationship. But the fact that some have is all we need to move forward and say EHS is caused by EMF. And one of the things that also hasn't been done in many of these studies, but if you're going to do one of these studies, should be, is objective observations in addition to their subjective history as you're doing the test, because it's not time locked and not 100% reproducible as a reaction. Now, I mentioned blood testing, and these can fall into many categories. I've tried to make these broad labels to show how the hundreds of potentially useful tests can fit in. Oxidative status, I think, is particularly useful at this point in time, where we think that one of the mechanisms is likely to be oxidative stress. And some are using blood-brain damage markers as well, and looking at general health level with things like vitamin, minerals and antioxidant levels to look at the other side of how much damage may have been done and how can we help by potentially supplementing. But I'm not going to go into detail here. Other speakers will, because there have been publications like this which point out some of the tests which have been shown to be altered in a statistically significant manner in this group. Now, why aren't they fully diagnostic? Why aren't they giving us 100% of patients? Well, there's a lot of explanations for that. And just one of them that I'd like to point out, because it's why I put my staging criteria together in part, is because I would expect that using my staging, stage 1 and stage 4 groups would not necessarily show any physiological change or physical change, because either their condition is too mild, we're at the very beginning, or because they're in full remission. So if this was brought into these kinds of studies, it might give us more of a clue as to what kind of levels of disruption we're seeing at what stages of disruption. And this is another paper that I mentioned scans as well. This group have done Kepler scans that they'll go into detail about, I believe. And again, really useful and interesting, and allow us, I see all of these tools at this point as being mostly useful for monitoring purposes. It allows us to see, well, do we see these abnormalities? And then if so, are they corrected by our management plan? Now, if our management plan was lowering EMF, and it works to correct those abnormalities, then we can be very sure that they were created by EMF in the first place. I only mention intradermal skin testing because this is used in many specialist clinics, and it's because of the multiple chemical sensitivity component. If you're aware of that via these kinds of tests, then managing that at the same time is very sensible to reduce the sort of total body load and reaction. Other tests that have been done in some clinics, I'm not advocating any of these specifically. I don't see patients, I'm in research, but I'm just pointing out that these are many of the common tests being done in environmental clinics. And there's a lot of sense in many of these in that they're looking at immune function and here looking at toxicity. Heavy metal toxicity I've mentioned could well be implicated. Another common sense approach at looking for that because it could be treatable. Looking at other diagnostics, there are lots of different types of assessments that have been published and put forward, and I've put some of these out here. We don't have time to talk through all of them, but I'll mention the last one, the lymphocyte sensitivity test, which I found very interesting because it's a straightforward blood test, very non-invasive and safe for the patients. And some research work has been done over here looking at the fact that if you take a patient with chemical sensitivity and you analyse the calcium influx into their cells in the presence of known common chemical toxic triggers, you can see that these cause increased influx through the voltage-gated calcium channels in the cell membrane. But what's fascinating and relevant to this lecture is that if you then put a low frequency, here in the UK 50 Hertz classically field, 60 in the States, in that study at the same time, that can potentiate or increase the reaction where more calcium enters in that patient group. And the lab that do this test over here have claimed to have done a large number of controls and found those not to have this same potentiation. So they see this as a diagnostic test for EHS, and I would love to see that validated on a greater scale. That's what we need for all of these investigations. If we're going to use them as part of diagnosis or management, we need to see wide, large-scale controlled trials to show that it's genuinely useful diagnostically or genuinely a good management strategy. So moving now into management, we obviously would like to prevent EHS. So having broadly increasing awareness and reducing the EMFs in our environment is really sensible and will lead to that outcome. But of course, in the digital age we currently live in, many people are developing this condition. And the mainstay of management is avoidance. So here's the A to H's that I put together as a very simple structure to work through primary care or in a cardiology clinic or in a pediatric clinic. If you see these groups of symptoms and you're suspicious, or if the patient is concerned, you can implement this immediately, and it's safe and in many cases very effective. So reducing exposures first, and then the B to H's is all about health optimization, and many people in this audience are experts in that, so I'm not going to go into detail about those aspects in this talk. These are just published guidelines, also recommending, as I do, that avoidance is the cornerstone of care. And this is repeated now in a huge number of papers looking at this subject. So avoidance isn't rocket science in that we remove these emissions or we shield them or switch them off. It sounds simple, but in practice it can be more difficult. Classically used techniques are flight mode, hardwired cabling, and swapping for alternatives that have lower emissions. But in the more sensitive patient groups, the next step is, and actually right from the beginning, you should be thinking about low frequency fields. They're a very occult source of EMF that very commonly gets missed. So People with EHS have often identified that phones and masks and computers trigger their symptoms because these are pulse modulated radio frequency fields. They seem to have a more obvious and acute trigger, but also they are identifiable in a patient's environment. What often isn't is the low frequency household wiring, because it's everywhere and it's on all of the time. So they don't often identify that as a trigger, even though it very, very likely is. So I recommend turning off circuit breakers, measuring the low frequency fields, making sure that they are as low as can be achieved. At night time, this is especially important, and this is good practice, I think, in general, whether somebody has acute symptoms or not. This is good, healthy practices to make sure you have low EMFs in the bed space, both of the higher and lower frequencies. For the very sensitive groups, you look at their triggers. Are they triggered by their cooking and heating units? They often are. Those can be changed for low EMF alternatives like gravity-fed oil systems, for example, or there are a number that aren't reliant on electromagnetic fields. Be careful of things like gas, which can create a chemical toxic response. ELF filtering, so using filters on the low frequency wiring to clean up the harmonics or dirty electricity can be useful. And shielding is obvious one. If it's you can perhaps shield one aspect of the house if there's a clear unilateral source. Camping I point out because I wanted to mention that there is the stage 3 EHS group. There is a sub-minority within that group who are exquisitely sensitive and are forced into things like primitive camping in order to protect their health, and that's really dangerous for them, not just because they're getting often such severe symptoms with EHS, which may be life-threatening. You know, we may be seeing cardiac dysrhythmias or even seizure-type activity reported by many of this group. That's serious, but then when they're in that situation, they may have extremes of temperature. They may be struggling to find clean food and water sources. Their entire social and medical support structure breaks down at this point, and I'm really deeply concerned. This is the group that we have an emergency responsibility to protect. Now, while we're talking about avoidance, I just want to touch on some of the points made by Professor Martin Paul about avoiding chemical triggers that may be activating the nitric oxide cycle through NMDA receptors, for example, and other triggers like overexertion in those with chronic fatigue syndrome, intense psychological stress in those with PTSD. These are things that will trigger very similar symptom constellations, and they may actually be sharing the same cyclical pathway there. And in addition, again, slightly occult, but that you must think of, mold, radon gas that might not be obvious, and other sources of EMF like the low frequency wiring that I've mentioned. That's all part of avoidance. And then we need to move through the B to H's, which is about general health optimization. And just to run through these very briefly, we're talking here about breathing fresh, unpolluted air as much as possible. Some of the heating units and air conditioners can generate ions. CBT I want to talk about, where we're here under cognition. CBT has been advocated in some publications as useful in the management of EHS, and I would say yes and no. Yes, in that it would be an excellent technique, for example, for managing stress reactions under stressful conditions where somebody cannot avoid EMFs. That's a classic use, and there'll be many others. Where it must not be used is to dissociate the relationship between the EMF trigger and the symptomatic response in a person. And what I mean by this is some groups have used CBT to tell people, don't worry about your phone, it's not the cause of your symptoms. That is the wrong way to use this, and it's a very unethical way to use it. We know that these kinds of exposures may be increasing risk, for example, of space-occupying lesions. So even in somebody who doesn't have an acute symptomatic response, it is not sensible to tell them that it's a safe habit to intensely use their mobile phone. And it absolutely must not be used in this patient group, because it could very credibly lead to health detriment. Dentition is really about mercury amalgams and whether you need a mercury aware dentist to give input here, and ideally one who's also familiar with EHS. I have commonly heard the story that people have developed EHS after the removal of mercury amalgams, where it's likely from the history that the mercury release may have triggered their condition. Conversely, the presence of the amalgams can form a sort of battery type and conductive pathway for radiation in the mouth, which is also probably unhealthy. So really you need expert intervention here to know how to manage that. Exercise, beware in chronic fatigue type patients. Friendly foods, what I'm talking about here is things like rich in antioxidants like glutathione, superoxide dismutase, for example, and many others that I recommend an organic rotational diet for this group, especially if they've got obvious food sensitivity. Grounding is sensible. We've talked about bathing techniques, but frequent grounding is good to stop build-up of static charge. Hydration, I often point out that glass bottles, spring water may be useful if they've got developed sensitivities to some of the common tap water contaminants or leaching of toxins from plastic in bottles. Sunlight and sleep, well, we want healthy vitamin D levels and we want a robust circadian rhythm, and we want the most natural daylight spectrum of exposures to light that we can. So that means healthy time outdoors and the omission of things like very high blue-white spectrum lights, especially high intensity, high lux lighting in the late afternoon, evening and nighttime, which we know can turn melatonin production off, which is very sensitive to that. And there's that whole lecture on sleep optimization, but I'll just say, it's essential. You can sometimes see a dangerous positive feedback cycle in those with EHS, where they get insomnia as one of the symptoms of EHS. That leads to chronic fatigue and sleep deprivation, and that makes them more sensitive. A bit like the way sleep deprivation can lead to lowering of the seizure threshold in people with epilepsy. So we want to stop that kind of feedback. Following moving through the A2Hs, I often say go back to the beginning, start again, because particularly in terms of avoidance, you can always normally do more if the person is not improving. And you must consider at this point adjunctive or other forms of management and investigation if you're not winning. Trend is absolutely essential. So if somebody, all things being equal, if somebody stays in the same environment and their trend is that they're getting better, they should continue to get better. And conversely, if they're deteriorating, that's a disturbing sign that you need to change something to get them on a better trajectory. What I would say is useful to know is that we can see really excellent results sometimes with very minimum intervention just by lowering EMF alone. In terms of when to refer to a specialist, obviously if you've gone through all of this very simple, safe protocol and they're not improving, if they're unable or unwilling to avoid, and I'm very sympathetic to this situation, not everyone has the resources for a little cottage in the countryside, and some people are forced into a situation occupationally or just for their living and sleeping environment that is far from ideal. And they may need really complex support and management strategies to try and help them improve their health. If there's complex environmental sensitivities, we often see these multiple sensitivities where mold and chemicals and a whole load of other toxic elements in the environment are causing sensitivities to even minute doses, and that can be very hard to manage and take a long time. If you're not sure about the diagnosis, you might have multiple specialists involved. Legal testimony, I just want to point out that actually primary care physicians or hospital specialists can absolutely give legal testimony about this, and we really need to see that happening. If you have attended conferences like this and read some of the peer-reviewed literature that you're being offered as part of the conference, actually there's no reason at all why you shouldn't be able to give a solid, credible testimony to support this group. And often that's actually the most valuable role you can play, because you can't give them the house in the country, you can't go in and disable their neighbour's Wi-Fi, etc. But politically and socially, there are constructs that can help support a patient to lower the EMF in their environment, and your testimony could be essential to that process. So please have the confidence to do that if you are confident about your diagnosis, and you might want a specialist opinion to corroborate that and give an additional testimony. This is, again, I'm not recommending these personally necessarily. I'm just pointing out that if you do refer to a specialist clinic, these are many of the interventions that you will see being offered. And I would like to see these trialed in a formal and scientific way against avoidance protocol, because I don't think we've seen that happen at this point. And actually, we can't recommend interventional therapies unless we know they are actually doing more than just avoidance alone. And they're usually prescribed together, so you don't know which one. And I do know that avoidance protocols can work from anecdotal patient groups here, and there are publications on this as well. But before we move on to more interventional therapies, we need to prove they're working. And in terms of an ethical way to do that, given that there is a group of patients that feel they can't avoid EMFs for one reason or another, or don't want to, those are the groups that might want to volunteer to be part of these kinds of trials. This is the kind of thing we're starting to see evolve that I'm really pleased about. This was looking at immunotherapy, in low-dose immunotherapy used for treatment of multiple chemical sensitivity, and it was shown to, in a very objective way, reduce calcium influx through the membranes of cells in the way that I described earlier. So these are the kinds of peer-reviewed publications that I'd like to see evolving with all of the different management strategies that are being advocated. Prognosis. Well, this depends really on the total duration of illness and the severity of illness or staging reached. But complete reversal of symptoms is absolutely possible, even for very severe later stage patients, if they are put in a truly natural EMF and chemical environment. And that can happen with no other medical intervention. However, in all cases, it's very common for symptoms to redevelop when that person is reintroduced to the most likely quite toxic environment that generated their symptoms in the first place. But their boundaries increase over time. So the longer that they've been well managed and well, the more they can increase their boundaries to a more and more normal lifestyle and seem to better cope with the kinds of exposures that they're forced to be exposed to undergo normal life. Whether it's going to a petrol station or a supermarket, will do their job. I'm going to give a classical case history now, and I've deliberately chosen a very simple one, partly because of the time constraints I have, and partly because actually at these conferences I've noticed that often we are sharing the most complex and challenging cases, which is fascinating for people who are already experts in this field. But actually what I wanted to do was bring in bread and butter type history of the most common patient that you're likely to see either in general practice or in a general hospital admission. This is a 45-year-old IT specialist, and he was sensitive to foods, chemicals and EMF, which is a very common constellation that we see. His history was that he started with food sensitivity in childhood, chemicals in adolescence and EMFs in his 20s. Now, this is really interesting, and there's another reason why I chose this particular subject to share with you. We have two different layers of evolution of symptoms that we should be looking out for. One is about the individual and their personal history of exposures, which you can only get from their history. But another one is the background, global environmental state. And he's about the same age as I am. And this generation had exposure to quite a few toxic chemicals in their young childhood, many of which have now escalated also. But EMS only really started to become very prevalent in the sort of adolescent or young adult period. And that's important because of my next slide, which I'll move on to. And he didn't have any other noteworthy past medical history, very otherwise healthy man. So when he first became suspicious that EMFs were causing his symptoms, he's an IT specialist, so he was quite cluey about the kinds of things that radiate. And he noticed that there was a link, and he then looked in the literature, scientific and medical, to try and corroborate that link. And he did indeed find sensible evidence that his suspicions were correct. That's very important. I'm about to explain why. And we have a unique window of opportunity to see this type of history that we're about to lose. So looking at the Bradford Hill causality criteria, the only one of those which is essential is temporality. If A doesn't precede B, A cannot be the cause of B. This is blindingly obvious. However, like I say, we have a window of opportunity to see this in this patient group in terms of taking history that we're about to lose, because this gentleman had no awareness that these types of fields could cause symptoms until he read. In a generation or a couple of generations' time, that will no longer be the case, because it will be so widely accepted that EMFs can interfere with biology and health that most people will all know that, in which case you can't show that there was no knowledge of health effects before the development of symptoms. Now, showing this in this person means that the nocebo response is impossible here. He can't possibly have had symptoms caused by fear because he had no fear. He was a technophile, he enjoyed using technology, his income was dependent on it, and he had no knowledge of health concerns. So his primary constellation was headaches, palpitations, visual disturbance, hearing sensitivity, and some balance issues or vertigo type symptoms. Very common and classical. Secondarily, he also sometimes noticed muscle twitching, numbness, tingling, weakness, thought block, and irritability. Again, common. Ophthalmological symptoms, I won't go into detail, but just to point out that these can be very subtle, they might be absent, but they are, as I mentioned previously, very typical of the symptoms seen in scotopic syndrome. So I really hope that more research is done there so that we can better understand. This will help us to understand some of the pathological processes if we can do better research. He had noticed, as I previously pointed out, sensitivity to some dietary triggers, grains, dairy, and cleaning products, particularly volatile ones, classical. Now, the symptoms in response to those are slightly different. They're more classically allergic with a little bit of overlap. These types of symptoms were interfering with his normal life. They were interfering with his use of computers, for example, and phones. These are things integral to his occupation, which brings rise to the question of disability. And I want to bring this into your mind because this can absolutely constitute a disability in this group, and it has been recognised in that capacity here in the UK. I know in the States also, dating back for many years now, and more in many other countries. And unfortunately, that will continue to escalate until we start to generally reduce exposures. But this is another important role for you as their physician, is to recognise that this patient may actually be disabled and need your support in having that recognised and supported. So relieving exacerbating factors, very predictable. In this case, it was computers, televisions, some kitchen appliances, and that was relieved by creating distance from the emissions. The intensity of radiation absorbed is inversely proportional to the square of the distance. So even moving something away a very small amount can quite dramatically reduce the intensity of exposure. So it's no surprise that moving things further away helped him. Shielding. He, again, because he was tech savvy, he tried alternatives that he knew were different or EMF lowering. In this case, an infrared keyboard. Now, this is an excellent idea because infrared radiation seems to be far better tolerated in people with EHS than things like pulse modulated radio frequency fields. So if you have to use a wireless device, that is a way that seems to be far better tolerated. And he did some other things like hard wiring and using a lower processing speed laptop and using his laptop with battery alone, not plugged into the mains, which we know reduces some of the especially low frequency fields. He did try some other things, some skin creams for the eczema and things, and often these aggravated symptoms, it never helped. He tried some supplements that were advocated by an environmental specialist clinic, but actually those made symptoms worse as well. The only thing which helped him was avoidance, and it was avoidance of his known dietary triggers and EMF. So I mentioned my staging program, and I talked through that with him. Using a visual analog scoring system, looking at severity, and stage 1 was where he started in about 1995, and that was because of high EMF at work, and he was in that stage for about 5 years. He moved between stages, which is very common because he worked out what was causing it. He then mitigated that in his environment. Sometimes factors beyond somebody's control increase the exposures again, and they can have a worsening of symptoms. But ultimately, he ended up in stage 4 in 2016 and has remained in remission ever since. So he, looking at the most effective management strategies from his report, it was EMF lowering, and all of the things that he did to lower his exposures were the most successful, and nothing else actually helped this particular gentleman. That is classically the report that I hear from this group. Now, in terms of prognosis, we can only give expectations of prognosis based on anecdotal evidence. We just don't have enough investigation and publication on this subject to be able to say anything more than that. But based on my involvement with this group over the last decade, I would say that this is a good positive trend. He's got control, which is one of the most important factors. Allowing a patient to understand what's causing their symptoms and feel like they have control over them is essential to moving forward. And actually, the A2H's type plan that he implemented in lowering his exposure, I think reduced his risk of other endpoint pathologies. Other things that have been linked with EMFs in the literature, things like various forms of cancer, neurodegenerative disorders potentially, infertility. So this kind of strategy is not just safe, it could well be health optimizing for other reasons as well. The one caveat I would leave is that he is an IT specialist. He is still working intensely with computers, using them for quite large proportions of his day. Actually, if he could divert away from that, that would probably improve his prognosis even more, to the point where he really noticed no symptoms at all. And but obviously his income is dependent on this, which is why as a society we need to be looking at better ways to support people in maintaining their career and their home life at the same time as mitigating. So moving forward on a wider scale, we need to see acceptance and acknowledgement in, we've got it in the scientific forum, in the expert scientific forum. We have acknowledgement of the role of EMF in disease processes, not just electromagnetic hypersensitivity, but a growing number of others. But what we don't have is that same recognition in the social and political forums. We need to see that in order to move forward. And we need accountability for exposures and action to try to improve. And with that in mind, many groups of scientists and doctors like myself have come together on this subject for many years and put forward appeals and statements. And this is one, the EMF scientists appeal. There was also the EMF call that followed that, which was asking for lower exposures generally. This was one from the Paris Appeal Conference, looking specifically at EHS and pointing out that along with MCS we need to be recognising and properly managing these processes. This was the 5G appeal, and they pointed out with some very strong language in this appeal that we have proof that these exposures are increasing cancer risk, DNA damage, structural and functional changes to the reproductive system, and many more pathologies, and asking for immediate moratorium on 5G. And in terms of my work with my group FIRE, I wanted to add my own voice to this group and continue to bring people together. And I want to say a massive thank you to all of the excellent medical groups who've endorsed this statement that I put together this year, that I've called the 2020 NIR Consensus Statement. Environmental specialists from all over the world coming together to say we have a major problem, and pointing out that we're looking at a public health crisis for various different types of symptom and disease processes, and that we really must take action as quickly as possible to prevent this impending disaster. And pointing out that that the current safety guidelines are not protective, that current levels are already harmful, but they will obviously rise with the introduction of the Internet of Things and 5G. some of the Human Rights and Equalities Act issues and contraventions of those, and the problem about advisory groups and conflicts of interest, which has been a problem throughout history when we've looked at other important public health problems like tobacco or asbestos. We really should grow out of reproducing these predictable mistakes. And so we're asking here for an immediate moratorium on further emissions and further increases in exposures, and the establishment of safety limits that are actually evidence-based on biological interaction. Withdrawal of emissions from within and nearby schools. I haven't spoken in this lecture about the vulnerabilities of children, but they are another obvious vulnerable group, and there can be no defence for their exposures to EMFs in schools, for example, where it's not essential on any level to the learning process, and there is such a well-described literature base now for risk. Designation of low electromagnetic field areas in public spaces, as well as housing areas for people who have acute symptoms, and indeed for people who just don't consent to exposure. There's an ever-growing number of individuals, some of whom have formed legal actions, for example, who are just simply saying, I don't consent to exposure, and they should obviously have a right not to be exposed against their will. Education programs exactly like this one, so a huge thank you again to this group, because this is exactly what my group Fire Medical are trying to do also, is be part of these conferences and international programs where we work together to improve our understanding, and a zero tolerance approach to industrial influences on public health policy, which is obvious but actually not at this point happening. So in summary, EHS is currently a clinical diagnosis based on history, and there are adjuncts which exist that can corroborate the diagnosis and help with monitoring. Exclusion of other causes, of course, is essential to the process, as it is in all good practice. Management should rely on avoidance of EMFs as the primary aspect, and there can be general health optimization to go along with that management protocol, which is extremely sensible. We need urgent protection for sensitive groups, and that is many different groups, including those with electromagnetic hypersensitivity. Please do feel free to join my group Fire at firemedical.org. It's free membership, and we are professionals from all over the world who have joined together to increase our own learning and understanding, and put together things like guidance documents and education programs to facilitate research. I'm really proud to point out that many of the members of my group are extremely well published with cutting edge peer reviewed research at the top of their field. And I want to say a huge thank you to all of those who are on the main steering group of my group, as well as all the members. And you don't have to be a medical doctor. Anyone can join this group in addition to show support or be made aware of important new initiatives. So huge thank you, and a massive thank you again to the EMF Medical Conference 2021 for bringing another light onto this rapidly evolving, important new area of medicine. Thank you so much for listening.